Hi, everybody. I'm a family doctor here in Vancouver. I'm also an assistant professor at the University of British Columbia. I don't have any relationships with commercial interests. I don't take any Speakers Bureau funding, nor do I collect any consulting fees. I get paid as an assistant professor from the University of British Columbia via salary, and I also build British Columbia's medical services plan, a fee for service, in my work as a family doctor. I have received generous grants from the Canadian Institute of Health Research and several other local funding agencies. Excited to be here.
This is me, Dr. Jessica Oddie, family doctor on Vancouver Island. I don't have any relationships with any commercial entities, nor grants or consulting fees. My clinical income comes through the medical services plan billing and some sessional payments and a service agreement for palliative care. I also get a small salary from the Therapeutics Initiative for education research activities like this. And there are various honoraria that I collect for policy and committee work, mostly around quality improvement. So I don't think those things will present any conflict of interest for the content today.
Hi, everyone. I'm Kate O'Sullivan, and I'm a pharmacist with BC's Academic Detailing Service. I live and work on the unceded traditional territory of the Comox First Nation on Vancouver Island, and all of the money for the work that I do comes from the BC Ministry of Health. I have no other conflicts of interest. Thanks.
Hi, and I'm Aaron Tajani. I'm a pharmacist and work for Fraser Health and the Therapeutics Initiative. I have no commercial interests, don't take any money for speakers bureaus, and have served as an expert witness in 2 legal cases regarding drugs and evidence, and currently no grants or research support. And I'm glad to be a part of this event today. Thank you.
So many of you might be new to this type of course, especially from us, because we've never offered this specific course. We've offered lots of critical appraisal and evidence review sessions in the past, and talked about specific clinical topics. But this format is quite different for us, and we're hoping to make it as interactive as possible with the limitations of Zoom. And this is our rough agenda for today. So we're going to do a little bit of housekeeping and introduction. Rita will talk to us about PICO questions in a little bit more depth than you may have encountered in the past. And we're going to be using a patient to help us explore that. And then Aaron will talk to us about getting the information that you need from a study, and we've chosen one today for the purposes of talking about COPD. But I'll remind you that we're not going to be covering all of COPD today, all the different treatments and considerations, but rather using this particular trial as an example of how you might look at it as a clinician and help to answer your patient's questions. And Aaron's going to help us figure out how to translate the information that we find from the study into something useful that you can communicate to the patient. And then Rita's going to help us wrap up with, well, what about what the guidelines say and how do we integrate that into our practice and our communications. As mentioned before, Kate and I will be monitoring the chat for questions. Kate is very knowledgeable about COPD and treatments around it, but we're going to try to avoid answering things that are really off topic and more focus on helping you to find the answers to your questions, and any logistic challenges that you encounter along the way. We'll be putting some links in the chat and so on to help out. And there'll be opportunity for questions throughout the session, as well as in the wrap up. And you can use the chat if you set it to everyone to ask any particular question. And if you want to remain anonymous, you can send something directly to Jessica or Kate. And big thank you to Eric Menka, who's helping us run everything. He'll be helping us with the breakout sessions later, and just making sure things go smoothly. Housekeeping, this session is being recorded today, so if there's anything you don't want to share, please turn off your camera or do not share it. We'll like to keep you on mute for the most part. There may be some cases where we ask you to unmute, but just the number of participants being almost 100 would be challenging for us to manage, so that's why we're asking for that today. We know it's lunchtime on the West Coast, and it might be coffee time out east. So if you are eating, please turn off your camera. I mentioned earlier questions, just put those in the chat, and we'll keep a running tally, and there'll be places where we pause so that Rita and Aaron can address some of the questions and the common themes. We've put a link in the chat, and we will do so again with the course materials, which are going to be posted on the Therapeutics Initiative website. Not all of the materials will be available after the session. I think the slides, for example, they're posted now. They may not be there after the session, although the recording will be. And we're going to put a link. I think Hillary has already put a link to the pretest, which actually about 80 people did. So that's quite good. And that was just to give us a sense of where you're at in your learning, but also help you consolidate some of your knowledge coming into this, and maybe challenge yourself in some other areas. And we'll have a link to a post-test and evaluation after that challenges your knowledge, but also provides us some feedback about the format of the course and content. And then the last thing is the post-test is required, as part of the evaluation, is required to get your continuing medical education credits. So once that is complete, then in a few weeks, Eric or one of our other colleagues at the Therapeutics Initiative will email you with a certificate. And at the bottom there, if you need to be doing lots of things while you're learning, you might consider tweeting. There's a few different accounts there. The drug evidence account is the General Therapeutics Initiative account. And then all four of us who will be presenting have accounts as well, and we're happy to engage there after today's session. I'm going to pass it over to Dr. McCracken to tell us a little bit about the course and what our objectives are for today.
Great. Thank you very much, Jessica. And thanks everybody. There's 100 participants on the line, which honestly, 100 of you came to talk to us or listen to us for 2 hours about critical appraisal. It's truly a sign that the pandemic has made us all do slightly unusual things, I think. But we're really, really excited that you're here and hope that this is going to be useful and are very interested in hearing your feedback about how it goes. So we wanted to take a new look at critical appraisal and apply it to a case in real life. So the patients who are showing up in front of you, how do you apply evidence to them? And so we're going to start with refining our clinical question. We're going to work on being able to find a reasonable estimate of benefit and harm for the patient in front of you, maybe not necessarily the patient who was represented in the trial. And we're going to consider different ways of how to present that information to a patient to make a shared decision-making, then do a little bit of discussion about how that shared decision-making result might be congruent or might deviate from what the clinical practice guidelines say about what you should be doing for treatment. And we hope that we'll be able to give you a few trusted resources for ongoing use of evidence and shared decision-making. In that folder, the link that Jessica has shared a couple of times now, there's 13 items, including a list of resources as well as a couple of specific PDF items. So that's the link. And a couple of years ago, I was talking to a friend of mine or via text, and I had just been in a meeting with some epidemiologists who had been convinced that every pharmacist, family doctor, and nurse practitioner could easily calculate the absolute risk reduction and relative risk reduction from a study abstract. And I was like, I don't know. I don't know if that's the case. I've just finished a PhD and I don't always feel like I can do it. And so I did an N of 1 test with a friend of mine, and he wrote back, "I'm not confident I even know what they are, let alone calculate them." And so then I thought, well, I'll try to do a little bit of teaching here. What I meant was the relative risk reduction is like the amount of the sale, all pants 50% off. So if the pants are $1, the new cost is 50 cents. Or if the pants are $100, the sale is 33. What are the pants going to cost? And then he humorously provided an erroneous answer down here. And so, this is not to say that math is hard. I personally find math hard, but that's not what this course is about. This course is about that we're clinicians, we are smart people, we have really important relationships that we maintain with our patients. We are barraged with massive volumes of new information constantly. And at the same time, the vast majority of us didn't go to do our clinical degrees to become mathematicians or epidemiologists. And so we're hoping that this might be able to provide you a little bit more confidence about finding that evidence, taking a look at it, and applying it to your patient. It would be great if the rumors or if the TV ads about drugs were real, that this drug will work for you. We know that as clinicians that human beings are not subjects of binary decisions where they do something or they don't do something. There's this complicated mess of life. I all the time eat in a non-evidence-based way, and I know how to interpret the evidence pretty well. So how do we rationalize, or how do I rationalize eating in a non-evidence-based way? Well, I've just been through a year's worth of the pandemic, and I have all of my history of how I was brought up about food as a reward. And there's all kinds of things that make us more complicated human beings. And so this area of needing to have a relationship with people in order to have better health outcomes. The study of it is called Relational Continuity. And I refer to it occasionally as the magic sauce, mostly because we haven't done a really good job in research quantifying exactly what that is for obvious reasons. But I think that this is a really important element that we need to consider as we are going forward. I'll come back to this a little bit later. So we chose COPD as the case study for this critical appraisal topic. When we first started talking about this in August last year, the triple therapy inhalers had just been approved by Pharmacare in BC. And for those of you outside of BC, we have a pretty good drug plan for residents of British Columbia, and not everything is covered. But there's a process that drugs go through. So there is coverage using a special authority process now for this triple therapy drug. And the other reason is that all of us have had an experience with a patient who's really suffered with COPD. It's a disease that can really affect people's lives, much different than, for example, atherosclerosis, where you have you might be having the effects of the disease, but you don't necessarily feel them. Whereas COPD is something that is present in many people's lives. It also uses a lot of health system resources. And so it's something where, we really want to be both helping our patients feel better, and we also want to try to minimize the impact on the health system. This is a case we're going to go back to again and again, Mrs. S. She's 66 years old. She's a non-smoker for 6 years. She quit 6 years ago. She's retired and she's extremely busy. She has a very highly exciting life. Even in the pandemic, she's still keeping very busy. She's had COPD for years, but she's otherwise well, doesn't have comorbidities that are slowing her down or on her mind. She's been on a dual therapy treatment, a LAMA plus a LABA. She's always gotten her refills on time. She did have an acute exacerbation of her COPD that resulted in a hospitalization last year, and she's just seen a TV ad for Ellipta with the new triple therapy inhaler and wonders if it works and if she should take it. So we are going to take this person and we are going to turn it into a PICO question. Some of you might be having some shudders about the PICO question and thinking, oh God, why are they going to make me do this? Why do we have to talk about PICO again? And we're going to talk about PICO again because it really helps frame exactly what it is that we are looking for from a study, rather than trying to absorb everything from those multi-page, tiny fonted items that often get thrust in front of us. So back to the magic sauce. Randomized controlled trials don't report in table 1 what makes a good day for the participants that were there. Each person has a different outlook on life about what makes them have a good day, and that ultimately is what we are trying to preserve as clinicians. And again, back to that relational continuity, there is some good evidence that shows us that there's some intriguing evidence. To call it good evidence would potentially be a little bit of an oversell because this is so hard to study. There's some intriguing evidence that tells us that if somebody's able to have continuity of care, there appears to be a protective effect for mortality. So let's, you guys don't know Mrs. S, but we're going to pretend that you know Mrs. S, and we are going to try to create a PICO question for her. As a reminder, the patient information for the P in PICO is age, comorbidity, sex, gender, race, social history, and then that idea of what makes a good day for her. The I is for intervention. What treatment, what is the treatment that we're considering prescribing? What are we comparing that to? Are we comparing it to her existing medications? Are we comparing it to nothing? Are we comparing it to another potential drug? What is it that we want to compare it to? And then the outcome, instead of does this drug work, what is the outcome that we are actually looking for? We want to apply that magic sauce and make sure that the answer that we're able to come up with allows us to work for this patient. Just in case you're really excited about becoming an expert PICO question writer, or you think that you might not remember this in the future, if you just Google PICO questions UBC, there's this lovely form that comes up. There's a million tools actually about how to create PICO questions. It's not hard, but I even find, again, even as a researcher, that I need to encourage myself to stop and figure out exactly what it is that I am trying to figure out. So the trial that we're going to be using as our example today is the IMPACT trial. We are not going to be experts at the IMPACT trial by the end of this. We are going to be using pieces of this, and we're going to be trying to expose a process that you could use to approach a randomized controlled trial. You all have a copy of this. This is available without any copyright implications. So we put a PDF version in the resources. We've also included all the supplementary materials and a very interesting editorial that was published in the same issue of the New England Journal for your interest. So we're going to break you out into breakout rooms. For those of you who have not done this before on Zoom, you are going to be dispersed through some process of technology into small breakout groups, into 3 people. And you guys are going to work together to create a PICO question for this patient. I will just note that since you don't actually know this person in real life, that what the drug working means to her is that it prevents future hospitalizations. She hated going to the hospital. She doesn't want to go back again. This year during the pandemic has really emphasized to her about how staying at an arm's length from formal health services works for her. All right, so you're going to imagine that you're her primary care clinician, and you're going to create a PICO question. If there's questions that you wish you knew the answer to beforehand, please make a note of those during your process, and that can be informative to us about what we need to do in the future. So, another resource that I just want to bring to your attention, I saw that there was already some chat going on in the chat boxes. I've made you a little cheat sheet for the drugs. I find, honestly, why do they have to make trials so hard to read? The way that the drugs are presented in that trial, it just looks like gobbledygook every time you look at them. So this is something that I have to do a lot of the times when I'm reading a trial, is actually write out for myself, what are the arms of the trial, the triple therapy versus dual therapy 1 versus dual therapy 2. This is a document that is available in British Columbia that compares the all of the elements that are included in the different types of puffers, as well as their trade names. And this document, which is really cool. These are British Columbia prices along here. This is also in your resources folder, just in case you need that as a reminder. So I will ask Eric to please put you into your breakout groups and take a stab at making a PICO question, and we'll see you back here in 4 minutes. Welcome back, everybody. There were a lot of breakout rooms. It was great. Just a reminder to everybody to keep their videos off and their keep themselves muted. So I'm going to show you what I put for the PICO question. And so she's a 66-year-old woman, no comorbidities, had 1 COPD exacerbation. She's taking dual therapy. In the study on page 1673, the last 3 paragraphs of primary efficacy outcome tell us what exacerbations are, because that's important, right? She wants to know if it works, and she wants her outcome of importance is to prevent going to the hospital. So we want to know, did this study actually look at preventing exacerbations that required hospitalizations? And the answer is yes, kind of. Sort of, it's mentioned, but it's not the exact precise outcome, but is incorporated into the primary outcome. There were other women in the study. And there were other people who had no other comorbidities. So she's probably present in this study, or a version of her is probably present. And she wants to know, is the inhaler going to work for her compared to what she is taking? And one of the arms of the study did compare to a LAMA or LABA. There are some important limitations around that, which we will get into as we're going through the story. All right, so thank you very much for participating in that exercise. We want you to keep all those things in mind as we start getting into the details. Just going to take a little bit of a left turn to Albuquerque here for a second and emphasize that this course is not teaching you how to use PubMed perfectly, how to get home to Kansas every time that you need to. And just another reminder that you should sign up for all the TI stuff, because that's a good place to get information. Another couple of ideas that we wanted to share with you about how to get information, how to get studies that come to you without having to necessarily spend a lot of time doing PubMed searches. You can sign up for a table of contents with journals that you're interested in. The BC Academic Detailing Service is amazing in terms of providing one-on-one or clinic-based teaching about various different topics. Lots of information there. mystudies.org is a website that summarizes randomized controlled trials and gives you all of the specific information out of it. pureevidence.ca, these are the people that do Tools for Practice and the Best Science Medicine podcast. James McCormick and the guys out of U of A, they produce some really brief yet evidence-focused pieces of clinically relevant information. And then if you're like, you really want to get something super, super, super specific, At your local library, probably has somebody like this nice lady right here who wants to help you, and you just need to send them an email telling them who you are. UBC is, every time I've ever reached out to them, they've just been ecstatic that I have contacted them. So choose CME that will review the latest literature and present it in a transparent way. This makes it even easier by choosing CME that you know has transparency about their funding, and are also share their methods that they use with you. So we recommend ourselves, of course, the provincial academic detailing, tools for practice. And if you have any other ideas for CME that you think might be useful, please share it with everybody in the chat.
Hey, Rita.
Yep.
I'm just going to interrupt you one sec with one question because it did come up, and we talked about this when we were preparing. How would you have known that this trial might be relevant to your patient to even search for it, for example? And you were giving examples of how you might have heard about specific trials.
Right. Yes. Good question. So for this particular one, I had actually last September, I think, reviewed the BC GPAC guideline, and they actually mention it as one of the only pieces of rationale for why the triple therapy is mentioned. It actually says the impact trial. And so that raised a question for me. So looking at, your usual places that you go, Up to date, a lot of us use Up to Date. And so you might notice, well, wait a second, they're saying that this is the estimated treatment effect. Maybe I want to take a look at that. And you can just, in Up to Date, you can actually just press the reference and it takes you immediately to the PubMed link. And you can actually then just press on that and it takes you to the whole article. So I don't think it's reasonable that we're constantly out there collecting papers and reviewing them in the evenings. You should be watching Netflix or going for a walk in the park instead in the evenings these days. So yeah, I think just taking them where they come.
Yeah, you had mentioned to me, I think you often hear about a specific trial at a conference, or you might see it referenced in a specialist consult note. We are doing this because of this trial.
Yeah.
Got it.
Thank you. So just to wrap up this section here, the magic sauce is real for all of you clinicians out there. I don't even need to tell you this, you know it, but relational continuity is a studied factor that appears to be beneficial to patients. Modify your PICO question in a way that uses the relational continuity, and make finding good quality evidence easier by curating your CME and your email inbox with sources that are transparent about their approach and biases. So feel free to pop up any questions there. Kate, Jessica, I think we'll hand things over to Aaron at this point. Aaron, you ready to go?
I am.
Okay, so I'll stop sharing and
Yeah.
I've started sharing.
Yeah, so hopefully, Rita, can you see my slides?
I cannot, but maybe it's because I still have the old ones up. Yes, I can now, but you're not in slideshow.
Okay, let's see. Current slide. Okay. It should just take a second. Is that better?
That looks perfect.
Okay, great. Thanks everyone for allowing me to take over for a while. It'll be a whirlwind. There's a lot of information to cover. We're already condensing it, so I apologize for the speedy move through the slides. But we're, as Rita had mentioned, we're open to discussing this further in the future, individually or through other sessions. So my section is hunting for the information in the study. So the question you should be asking is, will this study help me answer my question? I'll kind of explain the hamburger thing in just a second. So there's lots of evidence out there. It may not necessarily apply to the person sitting in front of you. So you need to reconcile that issue early before you start assuming that the effects seen in a particular study would apply or are possible with the human in front of you. So I'll give you some tips on how to do that. The way I think of it is being hungry is like doing fast critical appraisal. So imagine, I'm sure you've encountered this, you're in between meetings, you're driving somewhere and you realize, oh my, it's lunchtime and I need to eat. Or I have a patient coming to see me and they need to get some advice or recommendations on COPD, and I can anticipate I'm going to need evidence for that type of discussion. So, you know, you're busy getting towards the meeting and you have to make some compromises. You have to do the best you can with what you have. It's not as simple as dichotomizing, like I'm going to eat the best option or I'm not going to eat at all. You're going to have to grab some food and fuel yourself. So basically the approach we're giving you today is that driving in between meetings, I've got to eat kind of approach. So for example, you can't make your own food. You can't do your own critical appraisal in these types of situations. Home cooked food would be tastier. Or in other words, looking at independent and thorough systematic reviews of the evidence would be ideal, but it's not going to happen in this situation. Home cooked food would be healthier. A proper structured critical appraisal leads to a better understanding of the evidence. Again, ideal, but not possible in most situations for busy clinicians. And a restaurant meal where you're paying for really high quality food would take too much time and money. So commissioning the work of proper critical appraisal or going to paid resources is also not always feasible, but you still got to eat. So what we're suggesting is you opt for the fast food option. Now, keep in mind that generally speaking, trial participants are clean in quotations, much like the picture of the Big Mac that you would see in a television advertisement. They're less complicated than the patient in front of you, and you need to factor that in. Not always, but in many cases. Whereas your patient in front of you is a bit more messy, a bit more complicated. So what you see in the clinical trial versus what you can apply to your patient is going to be different. The effective drugs in trials are generally considered a best case scenario, the burger in the advertisement, where the effect that you see in your patient may not be the effect that you would see in the trial, because the person in front of you is very different. You need to do that reconciliation, and here's how you do it. So one of the first things to consider is, was there a run-in period in the clinical trial? So when they screened participants for entering the trial, did they have a period of time prior to the randomization where they made some decisions about these people were appropriate or inappropriate to be randomized? And you want to think about the implications of those decisions, because it directly affects whether your patient would have been allowed into the trial, or does it set up the trial to make the results look better or worse? So for example, did they exclude people who experienced an adverse event prior to being randomized? So they might have put someone on placebo for 2 weeks, and if those patients had a so-called side effect, they didn't get randomized. Well, harm in the trial where they screen people like that out would be lower versus the person in front of you potentially. So you need to factor that in, that the harm data from the trial may be an underestimate of what you might expect in real life. Did they include people who had a response? So in the lead up to randomization, they may include only people that had a change in their pulmonary function tests, or a reduction in their blood glucose, or a reduction in their LDL cholesterol. And if you only include people that have a particular response and those get randomized, you're leaving out the people that don't have an initial response. So the efficacy results in the trial may look better than what you would expect in real life. Did they stop previous meds, and what might go wrong as a result? So for example, many trials have placebo run-in periods where participants are exposed to placebo for a week or 2 weeks. Now, if you do well, you tolerate placebo, you're seeming to respond or not have new symptoms or don't have any complications, and you make it in, then those types of people may be less likely to experience harm in general in the clinical trial. So again, the harm data within the trial is going to be an underestimate of what you might expect. And what I do in my mind is I have a little set of notes. So every time I see one of these red flags as I'm reading the trial, I make a mental note of it. So then I know what filter to apply when I'm interpreting the results after I've finished reading. So for the impact trial, it's not in the publication, but most trials will have what looks like a flow diagram. 13,000 patients screened. Some people were excluded prior to randomization. So it's unfortunate that it's not in this particular publication, but in the appendix, you might notice that they report in this box how many people failed screening and how many people failed pre-screening. What they don't tell you is why. So why would someone fail the pre-screening? Did they have a side effect? Did they have a hospitalization? Did they have a so-called lack of efficacy feeling, and so they left? That kind of information would be important to know. I'll give you an example of a trial that does report a little bit more detail. I think about 15 years ago, they published the Tnt Trial of Atorvastatin, 80 versus 10. And in their flow diagram, which appeared in the publication, they talk about the people that were excluded. Now, all the people in the run-in were given 10 milligrams of atorvastatin prior to being randomized to receive either 10 or 80 milligrams. And the people that they excluded after 8 weeks of treatment with 10 milligrams of atorvastatin included people that had cardiovascular events, patients that had adverse events, people that did not comply with treatment. So, and also people that didn't at least have a small initial response in terms of LDL lowering. So you can see how exclusion of those people only lets in people that would have a better chance of a favorable outcome and a lower chance of having an adverse outcome within the trial. So it's essentially a cherry-picked population that's being randomized. That will affect how you relate the trial to your patient. So you need to ask, did the run-in include or exclude people making efficacy look better and or harm look smaller? This is what they say in the impact trial. They say that patients continue to take their own medication, which could include a LAMA, a LABA, or an inhaled glucocorticoid, or in combination during a 2-week run-in period before randomization. When the 2-week run-in was over, oh, sorry, my animations are a little off, but what they're implying here is that after that 2-week run-in period, whatever medications you were on up until that point were abruptly stopped. So the bottom line is some people, for example, were on inhaled corticosteroids and they did not get inhaled corticosteroids in the group to which they're randomized. So particularly the people that got a LAMA or LABA who might have been on a steroid earlier had an abrupt stop of the steroid. And you have to think about, is there a problem with stopping a steroid abruptly? And we'll get into a little bit of that later. So there's a little bit of this issue occurring in the impact trial. Now, this abrupt stopping of steroids may have made them more susceptible to exacerbations and may make the other groups look like they did better. It's not necessarily all due to the other groups doing better. It could be that the trial was set up so the people that didn't get steroids when they had them before are doing worse. Now, the next question we would like you to ask is, did this study include patients like mine, for example, Mrs. S? So you would look for something like the baseline characteristics table. It's generally table 1. And I ask questions like, did they have multiple morbidities, the patients that were randomized, and did my patient have multiple morbidities? I don't see patients anymore, but I'm speaking on your behalf. Were the people sick like the patient in front of you? Were certain people excluded, and do they resemble your patient? So if they excluded people like Mrs. S, and Mrs. S wouldn't have made it into the trial, then you're going to have difficulty expecting the trial results in Mrs. S. And what meds were they on? So Mrs. S was on LABA and LAMA prior to being considered for triple therapy, if you'd noted from Rita's slides. So you want to figure out how many people in this trial were on LAMA and LABA and then made it into the trial. And from this table, that information is not there. It's in other information, and I'll share with you what it says. So the bottom line is, shall my expectation be that my patient can achieve what happened in the trial? Now, the answer for Mrs. S is sort of. Only 8% of people that entered the trial were on LABA and LAMA prior to the study. So that excludes a lot of people like Mrs. S. But Mrs. S had one exacerbation in the previous year. She's a female and she's in the right age category. So there are some aspects that relate to Mrs. S and some that don't. So you're going to temper your expectations accordingly. The other thing that we suggest you do is look for common sources of bias. Now, just a cautionary note that when I say that something leads to bias and it leads to an exaggeration or maybe a misleading version of the truth, I'm talking about general statements. You never know exactly what's going on in a particular trial, but when you're doing fast critical appraisal, you kind of have that red flag filter in your mind about, if I see this source of bias, it's possible that it should color my interpretation of the results. That's all. The first one I think about is industry sponsorship. So industry studies have more favorable conclusions about their products versus non-industry studies of the same products. So you have to keep that in mind. I think my daughter is super beautiful and super smart. Obviously, I have a bias versus my friends' kids. I think she's way better than them. So it's that same kind of thing. So that does occur in the impact trial. You need to keep that in mind. Is it possible that in a blinded trial that blinding was compromised? And in the impact trial, it is possible. Blinding is really a bigger issue for subjective outcomes like symptom assessments, which were part of the outcome list in impact. Ask if anything could have broken the blind. Were key people or outcome assessors unblinded? Who exactly was blinded? Now, this study doesn't report those details. It says it was double blind. So you really don't know when they say investigators, does that include the people that did the symptom checklist? Did that include people that were statistically analyzing the data or actually treating the patient? Now, it's possible that the people who stopped inhaled steroids and didn't get an inhaled steroid in the trial might have noticed. So the LABA-LAMA group results may have been impacted by the fact that some of those people in that group were on steroids before and noticed that they weren't anymore. For example, inhaled steroids can cause dysphonia, and if you stop feeling that anymore, you might clue into the fact that you're not getting the drug that led to that. So in general, compromised blinding or open label studies can lead to exaggerated treatment effects, especially for subjective outcomes. So in this case, it might be happening for certain people in some of the comparisons. The other common source of bias is if a study has a primary outcome and they don't find what they want, they start focusing on the secondary outcomes, which is a sign to me usually that they're not wanting to emphasize something that wasn't what they expected. Now, in this case, exacerbations was the primary outcome in impact, and they do spend a lot of time focusing on that result. So in that sense, I thought impact was good. They didn't try to distract you away from their primary outcome, probably because they report or claim a reduction in exacerbations. Did this study provide data on outcomes of interest in a way that is useful? So not just they reported on exacerbations, did they give you numbers that made sense? So what I mean by that is you need to reflect on what your patient said was important. So Rita had mentioned talking to Mrs. S and figuring out what she meant by work. And what she meant was she didn't want to go to the hospital, presumably for an exacerbation of her COPD. So that should be the kind of information you start to look for in the trial. You impose the list of important outcomes that the patient identified for you onto the trial instead of passively accepting what's in the trial is important. So in this case, or in another case, if Mrs. S said, I really don't want to cough, but I cough a lot because of my lung condition, she's not saying anything about wanting her pulmonary function test to get better. You don't, in a quick critical appraisal, you may not want to pay attention to that kind of data and focus on the stuff that she's interested in. She doesn't want to go to the hospital, so we would suggest you look for the data that reflects all-cause hospitalizations. Just a word of caution, some trials will report disease-specific outcomes like COPD-related hospitalizations, or if it's a heart failure trial, they'll report on heart failure-related hospitalizations. we suggest you don't fall into that trap of looking at that in isolation. Look for all-cause hospitalizations. The reason is an intervention may decrease the disease-specific hospitalization rate, but increase the non-disease-specific hospitalization rate, leading to maybe a net no change in hospitalizations. So if you go too far down and focus the definition of the outcome, you may miss bigger signals of other interesting things. The bottom line is, do not assume the outcomes reported in the trial are all important or are reported in a way that is useful. So let's explore that a little bit further. So, for example, if you have a patient like Mrs. S, she had an exacerbation, but if your patient hadn't had an exacerbation and they do not want one, you would look in this trial to see if that kind of information exists. Now, this study reports the average rate ratios per patient per year of exacerbations. This includes people with 0 exacerbations in the previous year, all the way to people that potentially had multiple exacerbations, 2 or 3 or more in the previous year. So you need to figure out, do the numbers that they report for exacerbations, are they useful to me? So they get a checkbox for including an outcome that is important to your patient, but is the data interpretable? So this is the paragraph from the study that they report the rate of moderate or severe exacerbations during treatment, and they report 0.9 per year with triple therapy versus 1.07 per year for those assigned to the steroid and the LABA, and 1.21. So just imagine yourself explaining those numbers to Mrs. S and what do they mean? I'll put them in a different way for you here. So the triple therapy group after 1 year of treatment had, on average, 0.91 of an exacerbation per patient per year versus the numbers that you see there. So I want you to think about, when you see this, how would you explain this to Mrs. S? And I think it's also important to think about the baseline rate. In this case, these people came in on average. Most of the people in the trial had about 1 to 2 exacerbations in the previous year. Mrs. S had 1, right? So if you had 2 exacerbations per year in the year prior, now they're saying if you took triple therapy, you'd have about 1 per year. So you go from 2 to about 1. And if you took the steroid and the LABA, you go from about 2 to about 1. It becomes complicated. So you need to think about, is that useful? So for impact, what does a rate ratio of exacerbations mean? How can you reduce a portion of an exacerbation in one patient? So looking at those numbers again. They must have data on the number of patients with at least 1 exacerbation to be able to calculate the average rate of exacerbations per patient per year. So what these numbers mean, the 0.9 exacerbations, is if Rita had 2 exacerbations and I had 3 in a year, that would be 5 exacerbations in the treatment group divided by the number of patients. So that's 2.5 exacerbations per patient per year. That's the average for Rita and I. That's what they're reporting. Now, averages include a range. So that includes people that had no exacerbations, 1 exacerbation, 2, 3 per year. So it's hard to explain those kind of numbers to a patient. But in order to calculate those averages, they must have reported the number of people that had 1 exacerbation in the triple therapy group, or the number of people that had at least 2 exacerbations in the year in the triple therapy group, and to compare those numbers. So unfortunately, this trial does not report the number of patients that had at least 1 exacerbation. Now, I'm not saying the numbers they report are completely useless. I'm just saying that you need more to interpret them. And where do you find it? Now, unfortunately, in this, fortunate for us that Kate has read the clinical study report, which is thousands of pages. It's a public document, but it's not for the faint of heart. And in there, in table 23, Kate pointed out that they do report in a different document the number of subjects with an event. And in this case, it's, for triple therapy, 47% of patients had at least 1 moderate to severe exacerbation, and it was 49% and 50% with the other treatment groups. So I'm going to teach you how to calculate absolute risk reductions and numbers needed to treat later on, but in this particular slide, the absolute risk reduction is about 2 to 3% lower with triple therapy versus the other dual therapy treatment groups, okay? And again, this assumes that they're counting all the exacerbations that occurred in all patients, which we wouldn't have time to sort out in a fast critical appraisal scenario, okay? So then you're gonna have to share this kind of information with Mrs. S and ask her, is it worth it for her? So for every 33 to 50 people treated with triple therapy versus the other treatments, 1 fewer moderate to severe exacerbation would occur after a year of treatment. Now, is that effect meaningful for Mrs. S? You're going to have to ask her. If you assume you know what's important to Mrs. S, the studies would suggest that clinicians their view of what's important to patients is usually discordant with what the patients actually say is important to them. So it's a bad idea to assume you know what's important for me if you're talking to me. Now, one of the things is, can you even notice the effects that are recorded in clinical trials? Remember, the larger the sample size of the study, the smaller the effect that they're potentially looking for. So large studies are generally thought to be good. The thousands of patients in a clinical trial are a better representation of what the effect would be in a large population, yes. But from a statistical standpoint, if you're looking for a big difference in the rate of hospitalizations between one treatment and another, if the effect is truly large, you wouldn't need to randomize thousands of people to see it. But if the effect is small, you're going to have to include thousands of people to be able to detect a difference statistically. So keep that in mind. That just because there's a statistical significance between treatments for a particular outcome in a study doesn't mean it's something that would be meaningful for any individual patient. So here's an example about that. Which relates to the next question. Is the data in the trial complete, or is the information that you're seeing in front of you missing some key components, or did they not follow everyone for all the things that could have happened to a patient? For example, I start the IMPACT trial, and within 3 months, I don't come back for study visits. And then subsequent to my not coming back for study visits, I have 2 or 3 hospitalizations. You want to know if they counted those hospitalizations or if they just assumed I didn't have any. Typically in trials, when people aren't followed for the entire duration of the trial, they make some assumptions and they assume that nothing bad happened to the people that weren't followed, or there was no change in their condition. And in some cases, these assumptions are not always fair, and it would lead to information in the trial that isn't complete. And that's referred to in some situations as attrition bias. Now, when you compare trials that have complete follow-up to those that have incomplete follow-up, what you find is a mix. And what I mean by that is it'll either show exaggerated treatment effects or underestimate the effects of treatment. The bottom line is trials that miss information tend to be a little bit further away from the truth than trials that actually follow up people till the end, but in either direction. So not always favoring the treatment, sometimes against treatment. The bottom line is you're not getting the truth, which is what we're looking for. Now, if you look at table 2 in the IMPACT trial, you'll see when they're talking about the St. George's Respiratory Questionnaire, that's a measure of symptoms or quality of life or respiratory health. One thing to look for is how many people they were randomized, and you'll see at the top of the table, they say about 4,100 people randomized to the first 2 treatment groups and about 2,000 people randomized to the third treatment group. And then down here, they say the number of people that were evaluated for this score. And it's about 1,000 people different for the triple therapy group. About 1,000 people are not evaluated for the steroid group, and about 700 people less for the LAMA-LABA group. Now from this, I can't tell whether they assume that those people that weren't evaluated had no change in the score, or they had worsening of their score or improvement in the score. I just have a clue that the number of people they analyzed is less than the people that were randomized, and if I know that this attrition can sometimes lead to results that aren't actually the truth, then I know that the claims being made from an analysis like this that doesn't include everyone isn't probably super accurate. I don't know how else to say it. I'm going to use this information, but I'm going to apply a filter to it. Do I believe the claims as they are stated, or do I have a sense that I may not expect exactly what the trial is reporting? In terms of completeness or usefulness, it comes through in the impact trial again in terms of the usefulness of the change or improvement in the quality of life scores. So what they report is a mean improvement in the SGRQ score. They don't report, well, they do report the number of people with a meaningful, noticeable improvement, but we'll get to that in a second. So if you focus on table 2 again, in the methods of the impact trial, they state that a 4-point change is the minimum change in the SGRQ score that is meaningful. And when you look at table 2, they report that the difference in treatment groups versus triple therapy for the score is only a 1.8-point change in both groups. So that's less than what they consider or stated was a meaningful difference. So statistically, they detected an improvement in the SGRQ score with triple therapy, but it doesn't cross the threshold of something that is clinically meaningful or noticeable by the patient. Now, they just in the line below, they do report the number of people that had that meaningful change. And what we suggest is if that's there, you might want to focus on that instead of the numbers here. Now, another word of caution, remember the difference in the number of people evaluated versus the number of people randomized. So they're reporting a response rate only in the people that were evaluated. So that actual number might be better than what they're reporting or less impressive than what they're reporting because they didn't evaluate all participants. So when you're expecting an improvement in symptoms with Mrs. S if she chooses to take triple therapy, but she comes back and says, I don't feel better, then you wouldn't, based on these results, you know that the reported effect may not be what you can expect in the patient in front of you. The other thing that we suggest when you're looking for information in the trial is looking for minor and serious harm. Oftentimes in clinical trials, I found that they underemphasize the results of harm. And it's important that when I read trials, I always put that at the top of my mind so I don't forget or I don't get led astray by the writing in the trial to steer me away from paying attention to that. I don't think the impact trial goes out of their way to steer you away from the harm information. I think it's reported. So in this case, I would suggest you just pay attention to what they're reporting. So our suggestions are look for serious adverse events, and serious adverse events are generally any really, really bad thing that happens to patients that leads to hospitalization or death or is life-threatening. And in this trial, they report that in the results section, and without reading the paragraph for you, you'll see that they report no meaningful differences between groups in the number of patients that had at least one serious adverse event. It's the bottom half of the paragraph. Look for adverse events leading to withdrawals, and it looks like the rate of adverse event that led to withdrawals is lower in the triple therapy group, 6% versus 8% versus 9%. So that's potentially a good thing. And then you also want to look for known problems. So with the treatment interventions and the comparisons groups, if you know there's an associated with problem with that, for example, with inhaled corticosteroids, we know that there's a risk of pneumonia, then you would want to pay attention to the rates of pneumonia in the triple therapy group and in the dual therapy group, the one that had a steroid component. And in the next slide, you'll see that they do report that. So that's good. Look for known problems as I said, pneumonia with steroids in the IMPACT trial. They report the steroid group had 7 to 8% pneumonia. You can see that in the bottom part of the table, the white row. And in the umeclidinium bilanterol group, there's a 5% risk of pneumonia. 5% of the people had at least one episode of pneumonia. And you could present that in different ways to the patient. Again, we'll go through some of these ways later on. You could present it as natural frequencies. So for example, 5 out of every 100 people that received a non-steroid inhaler had pneumonia, whereas patients that received triple therapy, 8 out of 100 patients developed pneumonia within the course of a year. Or you could present it as a number needed to harm, 100% divided by 3%. So for every 33 people that received triple therapy, there was 1 extra episode of pneumonia within that year, or 1 patient developing pneumonia within that year. And then I don't know what Mrs. S is going to understand more, the number needed to treat or the natural frequency, but I would give her both and see if she understands one of them, and then ask her how she feels about that risk. Is that worth that risk too much for her to want to take triple therapy, or is it an acceptable risk? And whatever she decides is a good answer. So some take-home messages for you. Are the efficacy or safety results likely for my patient? Is your patient anything like the people that made it into the trial? And if your patient is, are the results of that trial likely in someone like that, someone sitting in front of you? Are there any common sources of bias in the trial in front of you? And biases generally lead to exaggerated treatment effects, or in other words, exaggerations of efficacy, lower risk of harm versus what might happen in real life. In general, you want to use that filter if you identify those sources of bias in your trial. And are outcomes in the trial important? And are they reported in a way that's useful to you? So think about symptom treatment outcomes differently from prevention outcomes. I'll talk more about that later. And determine if the reported differences in the trials are meaningful. So it's that whole idea of just because they find a statistical difference doesn't mean your patient will find that effect size important enough for them, or they would even notice it. And finally, always look for serious and minor harms and known harms related to the drug therapies that are involved in the clinical trial. So Rita, I think we stop there for questions.
Yeah, it looks like, Erin, there's a few comments on the best way to translate effects in conversations with patients and questions about BNNT. I think you have information that talks about that.
That'll be coming up a little bit later in your second section, right, Erin?
Yeah. Mm-hmm.
There was a comment that pertains to your summary there, if you don't mind still sharing your screen. It was earlier on, I think Mark McConnell was pointing out that, we can never really tell, as you've said, in an individual patient if a preventative thing has worked. There's no way for that person to know if they're the lucky one who benefited from that. And I thought that was important to emphasize, because that pertains to almost all of these kind of drugs and trials, and it can't be said often enough.
And in the next set of slides, I'll walk you through that idea of when it comes to using a therapy for prevention, you have to accept that discomfort of, for Mrs. S in front of you, if she has the event you're trying to prevent, what does that tell you about, did the drug work in her or not? Or if she comes back and says, I didn't have an exacerbation, thank you, doctor, for helping me, should you take the credit? In some situations, like Mark is saying, you can't really tell. But I think it's important to maybe try to figure out a way to communicate that to patients so that you set their expectations accordingly. Like, the drugs don't stop you from having events or not. It's not a dichotomy. They'll probably reduce the risk of having an event in some people. I can't predict if it's going to be you or not. So that's the reality. And learning how to communicate that to an individual, that magic sauce, I think is interesting.
I think maybe just one question before we move on to that section. I know there's lots of chatter about NNT and how to communicate, which you'll be touching on some of the evidence there. There's just a bit of back and forth about, like, you know, but doesn't this looking at papers in this way, analyzing them with these type of questions, doesn't that take a really long time? And others say, well, once you get used to it, you can do it quite quickly. I don't know if we want to make one final comment on that before moving
Sure.
onward.
Yeah, it's like anything. I think it does take time, and some of these things aren't easy to find when you haven't practiced. So there's two parts of it. You're going to have to make some compromises if you're in a position where you're seeing patients and you have a life and you don't have the time I have to read papers. You're not going to get the most detail and best interpretation of the evidence, but you have to do the best with what you have available to you. But the more you do fast critical appraisal or slow and more thorough critical appraisal, the better you get at it, and the bigger things appear to you, or things rise to the surface faster. So if you get in the habit and the groove of, I've got 10 minutes to look at a paper, I'm just going to look for these highlights. Does my patient fit? Are there any common sources of bias? Is the data presented in a way that's even reasonable? You're going to get better at it. And in the interim, there are places like the NNT website, the nnt.com, or the Alberta group, the Tools for Practice, or the peer group work, or there's summaries of evidence in the TI that you can use to supplement you getting to the place where it becomes easier for you. So,
well, why don't we dive into the next segment?
Yeah, we're
Okay.
running a little bit over time, but I think the guidelines section later, we can shorten that up a little bit.
Okay, I'll try to make up some time if I can. So let's go on to translating study findings into shared decisions. And remember, I haven't seen patients for a long time, so I'm not the best person. I'm just going to give you suggestions, and the clinicians in the group will, please feel free to jump in. These are just our ideas. I'm sorry about that. So, for example, category 1 would be an outcome where the patient wants some symptom or sign to go away or something to improve, versus the outcomes where you're trying to prevent complications. So patient doesn't want to be hospitalized, they don't want an exacerbation, they don't want a heart attack, stroke, those sorts of things. And the reason I suggest the categorization is because I think the way you use evidence and monitor for the effect in an individual patient differs depending on the above categories. Okay, so let's start with signs and symptoms. The trial results for the outcomes that relate to the treatment of signs and symptoms help you set expectations about what might be likely in your patient. However, what the patient tells you is the best evidence for the effect in the patient in front of you. So what I mean is, if Mrs. S said, I have lots of symptoms and I want to try the triple therapy inhaler to see if the symptoms go away, and you look at the evidence from the trial and it says, it's very unlikely that triple therapy improves symptoms in people that are symptomatic COPD patients. So Mrs. S tries the triple therapy inhaler and comes back to you and says, oh my gosh, it worked wonders. My symptoms are so much better. I suggest you don't argue with her. If she feels better, she's not experiencing toxicity, she's aware of the long-term harms, and she feels better, then you're not going to suggest to her that the evidence said it's unlikely, and she's probably not feeling the truth. You trust her to tell you that she's feeling something or not. Now, if she comes back and says, I don't really feel any different with triple therapy, then you reflect on the evidence that says, not everyone feels better on triple therapy. Some people don't have an improvement in symptoms. So then you're not surprised when Mrs. S says something like that to you, and say something like, well, some people got better on triple therapy. I'm not sure you saying that you didn't improve is reasonable. You obviously wouldn't say that. So what I'm suggesting for signs and symptoms, those types of outcomes, the trial data helps you set expectations, but the best response or the best idea of what your patient is experiencing is what the patients tell you they're experiencing, straightforward. Now, this can also apply to dose response. So if the trials don't talk about, well, if a patient comes back not feeling well on the lowest dose, try a bigger dose, then that's going to have to be a clinical judgment. I don't really know if there's a dose response, but if you're willing to try more and try it for a reasonable duration of time and come back and we can discuss how you feel, then that's probably the best way to deal with it. Or if the patient has a limited response on a particularly high or moderate dose of any particular drug and they don't feel better, you could try reducing the dose. And if the patient doesn't get any worse, then maybe a lower dose is better for them. So what I'm going to talk about next, I think, is the grouping of outcomes that are related to prevention. And in this case, Mrs. S identifies that she doesn't want to have an exacerbation that leads to hospitalization or hospitalizations. Now, I'm just going to refer to my notes so I know what I'm talking about. Actually, sorry, before I do that, my next slide will be symptoms and what impact says and how it reflects on Mrs. S. So in the preamble, we said she's not really complaining of symptoms, but let's say she was, and she was like the impact trial participants, which had a symptom level of, they were having at least some mild to moderate symptoms, most of them. So in that case, if she's willing to try triple therapy versus her current therapy, she could try one and come back after one inhaler's worth and talk to you about it. And if she says her symptoms improved, you could ask her, do you want another inhaler? If she says her symptoms did not change, you could ask her if she wants to stop. Now, because it has a steroid component in it, you would want to be careful about abruptly stopping a steroid inhaler. That's the kind of way I think I would deal with a situation like that. Next, please, Rita. Okay, so for example, in this trial, they actually report the number of people that had a meaningful change in their symptom score or the SGRQ, and I've listed it down there. And what they're showing is, and I know you'll have questions or you have questions about NNT, and I'll get to that, but they're showing 42% of people in the triple therapy group had a meaningful response or improvement in symptoms versus lower percentages in the other two groups, which leads you to a calculation that says for every 13 people that used triple therapy for a year, one more person had a meaningful improvement in their symptom score. So that means for every 13 people treated, one received the benefit, the other 12 did not. Okay, so in my mind, the likelihood is there's a 1 in 13 chance of me feeling better if I took triple therapy. Now, that may be worth it for some people and not worth it for others. Okay, and they're basing this on a minimum change of 4 points in that particular score. So you can take this information to Mrs. S and say, this is the chance in the population studied for a meaningful improvement. However, if you take it and you feel better, that's what we're going to use as the best judgment for you. And if you take it and you don't feel better, we're going to react accordingly. Next slide, please, Rita. So now moving on to prevention outcomes. Trial data for prevention outcomes helps us understand the likelihood of that benefit or harm in the patient in front of you. But it's hard or impossible to tell if the treatment is having the effect in your patient. So there's a slide later called Moderate to Severe Exacerbations Impact and Mrs. S that we'll get to. But what we suggest is there's no perfect way to communicate this kind of information to patients. If you look at the literature on this, some people really understand numbers needed to treat and some people don't. Clinicians, in my experience, have difficulty understanding it. There's some evidence to suggest that presenting natural frequencies are better understood by more people. And there's other evidence that suggests if you use visual decision aids, people feel better about their decisions and are better able to understand what you're trying to communicate. So next slide, please, Rita. I suggest you try different things until you get a sense that your patient understands it. Now, we're talking about NNTs today because a lot of people talk about them and a lot of people use them. I'm not suggesting that you use them or don't use them. And it reminded me of owning a cat, if you're considering a cat. Now, no disrespect to cats. I've had one in the past, but some people love cats and some people really don't like cats and don't understand why cat owners are cat owners. Lots of people have cats, and if you consider getting a cat, you kind of need to know what you're getting into. If you want a really cuddly pet that's always around and looking for attention, yeah, you might not get that. We're not suggesting that cats are bad or good. You just go in with your eyes wide open. Next, Rita. So how this relates to numbers needed to treat. Some people find them useful, some don't. They're discussed a lot in healthcare, and if you're going to use them or consider them, we suggest you pay attention to the next few slides because there's some weird things about them that you need to understand. Okay, next slide. So how do you calculate a number needed to treat? There are many resources online. This is a simple way. Usually they say only calculate a number needed to treat if the difference between the event rate in the treatment group and the control group is statistically significant. So you take the percentage of people in the control group that had the event, like a hospitalization, and you subtract the percentage of people in the treatment group that had the same event, hospitalizations, and that gives you an absolute risk reduction. You take that absolute risk reduction and you divide it into 100%, and that gives you the number needed to treat. Relatively simple math. And you would do the same thing for number needed to harm, except it's for the harm outcome. Next slide, Rita. Thank you. So, example, we had mentioned that there was a table in the clinical study report of the number of people that had one moderate to severe exacerbation in each group, and the numbers are listed there. So the first step is if you took the fluticasone bilanterol group, the rate in that group is 49%. You subtracted the 47% of people with triple therapy that had that same outcome. The absolute difference is 2%. And then for the other comparison group, the LABA-LAMA group minus triple therapy, the absolute difference is 3%. Take that information to the second step, which is turning it into a number needed to treat. So the number needed to treat to prevent one moderate to severe exacerbation for triple therapy versus the steroid plus LABA is 100 minus 2. So that's 50% or 50 patients. And the number compared to the LAMA-LABA is 33 patients. So next slide, Rita. Let's talk about what that means. So you could take that information from that data table and use natural frequencies and say 47 out of 100 people treated with triple therapy experienced at least one moderate or severe exacerbation versus 49 out of 100 people with the steroid LAMA group. So there's 2 fewer people that had a moderate to severe exacerbation for every 100 people treated with triple therapy for a year. Now, some people will understand that and some people won't, and then you could try giving them the number needed to treat, which means, or which you would say something like 50 people treated for 1 year with triple therapy is to gets you one person not having a moderate to severe exacerbation with treatment for a year. Next slide, please. So what does that mean for the other 49 patients? Some of the 49, it doesn't mean that all of the 49 patients, the ones that didn't get the benefit, will have an exacerbation. Some of them will and some of them won't. Can you go back a couple of slides? Yeah, right there. One more slide ahead. Yeah, and you can click through, actually. Yeah, that's perfect. So for every 50 people treated, one will not have a moderate to severe exacerbation. For the other 49 people, that means some of those 49 will and some of them won't have a moderate to severe exacerbation. And you can predict who it's going to be. So if your Mrs. S does not have an exacerbation after 1 year, is she the one? Well, you can't really tell because she could be the one, or she could be one of the other 49 people that wasn't going to have an exacerbation anyway. If your Mrs. S does have an exacerbation, she's definitely not the one because she had an exacerbation, but her chance of being the one that didn't have the exacerbation was highly unlikely. There was only a 1 in 50 chance that she was going to be the one to benefit. In other words, 49 people do not get the treatment benefit and only 1 does. Now, for some people, those odds are worth it, and for some people, it won't be. But you need to figure that out for the patient in front of you. You can click to the next bullet, Rita. Thanks. Now, keep in mind, again, we're not telling you to get a cat or don't get a cat. Same thing. We're not suggesting that we like numbers needed to treat. There's a really healthy debate about how you calculate them, what they mean, how useful they are. We're suggesting that if you use them, you need to be careful about making sure you understand what they mean before you subject your patients to try to understand it. Next slide, please. The closest outcome in the IMPACT trial that relates to Mrs. S not wanting a hospitalization is the risk of severe exacerbations, which are those exacerbations that led to hospitalization. Again, this outcome is not in the publication. You would have to look for it elsewhere. So I understand that as a limitation in the fast critical appraisal approach, but because I figured you'd be curious, we thought we would share it with you, and thanks to Kate, the numbers are here. And you can see severe exacerbations occurred in 11% of triple therapy group versus 11% of the LABA steroid group versus 13% of the LABA-LAMA group. And here's some examples of how you would present them as natural frequencies. And again, you would have to take that kind of information and share it with Mrs. S and see what she understands. And she might understand the number needed to treat. And then you have to ask her, is that worth it for you? And then let her decide. Next slide, please. Also, information that's not publicly or easily available, Kate pointed out, is healthcare resource utilization in this study. So how many people in each treatment group needed emergency room visits, other types of healthcare interactions, and there's no meaningful difference between any of the treatment groups in access to healthcare, you'll see here. So if her primary goal was any healthcare utilization, including emergency room visits, switching her from LAMA-LABA to the triple therapy is unlikely to lead to a reduction in her risk of requiring a healthcare visit. Next slide, please. So how do you explain this kind of information to a patient? This is sort of the magic sauce that we're talking about. I don't see patients, but I have a lot of friends and family and students that ask me about this, so I'll share my experiences with you. And Kate and Rita and Jessica and I have talked about this, and here's some of the things that we think you should try. Try to use plain language. Don't use jargon. It confuses people. In my experience, when I use jargon and I ask myself, do I actually know what I'm talking about? I often don't, and it takes me a while to think about it. So try to use plain language. I always tell my students, try to explain treatment effects like they're trying to teach my mom about triple inhalers, and that helps them. Use the teach back method. Explain something to your patient and ask your patient, what do you understand what I was trying to tell you? Can you tell me what you think you heard? And then you'll get a good sense of if they understood. There's pretty good evidence for decision aids making people feel better about their decisions. So I think if the magic sauce is important to you and relationships are important, then making people feel better about their decisions is a good thing. So try decision aids and try to gather resources for the most common meds and most common conditions you're likely to see in your practice. We suggest using natural frequencies as well, and try to see if the patient gets it, and if they don't, try other methods. And remember, adherence to medication is not the goal. There are some people that do not adhere to the medications that you suggest, but they've made an informed decision to do that. So we do not suggest policing people for adherence. We think questioning them about adherence is the perfect opportunity to talk this up and practice this kind of language. So I think that's it, Rita. You can go to the next slide. I won't go through this other than to say that try not to use the word work because it implies drugs work or don't work. It's a dichotomy, which it isn't. And just be kind to your patients. And I'll leave it at that, Rita. Sorry for being over time.
No problem. There's been some great discussion in the chat about how you actually present this information to patients. And that is, we're going to do an exercise now where we think about that. And we take a look at the guidelines. So please keep putting your comments in the chat. And Jessica, if I could ask that you advance the slides. One more, please. So I remember when I was a resident a few years ago, I had this fixed false belief that guideline-based medicine equaled evidence-based medicine. And there is a lot of evidence in guidelines, but it is not the same as truly you're not applying exact studies to every patient. And honestly, that is not possible. And so guidelines provide us one source of information that is very common. I work in a large urban clinic with 12,000 patients. I have 16 primary care colleagues, and we use guidelines because we don't have time to do an evidence review for every single clinical encounter. But there's grains of salt that need to be sprinkled on those guidelines. And there's also some guidelines that are better than others. So there are over 12,000 guidelines available handily for primary care clinicians. I have not read, 1,200. I've not read the 1,200 guidelines. I do occasionally go and look for one, occasionally. There's been tons of stuff published about the consistency and quality being an issue. For example, there was this interesting review of 52 clinical practice guidelines about diabetes, and there was some alarming inconsistencies and lack of transparencies around them. And so you need to try to pick the best guideline. And there are some really good ones available in Canada. And we will, those are available on your resource list as well. Next slide, please. In British Columbia, we have an organization funded by the Ministry of Health that produces clinical practice guidelines. I believe there are about 52 right now available for primary care clinicians. There is one about COPD, and we're going to take a look at that. Next slide, please. You probably have all seen a version of this before, the stepwise approach to escalating COPD medications. And you can see at the top there, step 3, to prevent exacerbations, says triple therapy will help. Next slide, please. We're going to go to the next slide again. Maybe next slide. Yes. Okay. So we're going to do another group activity. And what we're going to do, next slide, please, Jessica, is we're going to get into our groups of 3 people again, and you're going to use the GPAC guideline, the entire content of which is available in the resource pile. And I want you to take a look as a group of what the guideline says about how medications will reduce hospitalizations, how the guideline describes the likelihood of treatment effect, how possible harms of triple therapy and specifically are described, and what guidance is provided about reassessing therapy or proposing trial periods or when to discontinue therapy. And I will just say, if you haven't already figured out how to use your PDF reader, your Adobe or Preview for Word Finder, I literally put in, we've missed, so we, you can just word search for these things within the guideline, which can make it really easy to do. So I will ask Eric to please put everybody into the groups of 3, and you're going to have about 6 minutes to take a look at the guideline, and then we're going to talk about it as a group when we come back. So looking for people to type some responses in the chat to let us know what you found useful or surprising about the guidelines, particularly in the context of creating shared decisions for treatment for COPD. And I'd invite Jessica and Kate with their clinical hats on to make comments about how we rationalize what the instructions are in the guidelines versus what a patient might want.
Yeah, so there are now quite a few guides, critical appraisal tools, recommendations on how to create trustworthy guidelines. And one of the big things is providing information on benefits and harms so that clinicians can clearly discuss the information with patients. So I'm looking in the comments here, not much discussion of harm is mentioned. Did not seem to provide information quantifying benefits. And I think that's often what we're missing in guidelines. Increasingly, there are good examples that provide evidence summaries so you can see in absolute terms the benefits and harms. Someone says guidelines not really evidence-based, just consensus of experts' opinions. Someone pointed out under triple therapy, they indicated it would be recommended if someone has 2 or more exacerbations, so wouldn't be applicable to Mrs. S. That was Mary who mentioned that. And I did see a rationale for how they decided the cut point of who to offer triple therapy to. So that was sort of an outstanding question for me.
Yeah, and a few of us have sat at the GPAC table trying to help make those guidelines, and what you're seeing is pretty representative of the process. It starts in evidence, but then it gets adapted for clarity and brevity and according to clinicians' interests. So I think the reflections that you're having about, it doesn't really talk about a lot of the things that were in our questions. I think the first 4 questions, like they just weren't in there. So often the guidelines just don't address the things that maybe we're or our patients are interested in.
Yeah, it's funny. My observation is that you need to consider guidelines. There's no choice. Sometimes you're judged by guidelines in terms of medical legal issues, and that's considered the standard. So you need to be aware of them, and there are some good things in guidelines. You just need to remember that the patient in front of you, if you're in their position, you might want extra information about the likelihood of me getting harmed or benefit. And so you're going to have to supplement what you see in guidelines with some information and just get ramped up for
That's
that.
a perfect segue into Rita's next steps.
That's right. Yes, I'm going to share a few of the things that I do in terms of presenting information to patients and how I document it. And I just will comment, Raj has made an excellent point here about one of the really useful things that I find in the BC guideline is at the very end, there's a summary of all the available medications and a picture of each one of the inhalers. And I have used that many times. There we go. Kate is also holding up having a picture of what the thing looks like. I don't know how many of us have had the person come in and say, but the yellow pill, dear, it's the yellow pill that I want the information about. I have no idea what the yellow pill is. So I've had, Mrs. S is not my patient. I've had patients like Mrs. S, and I often find that when I explain what I have taken away from a study, they're unimpressed by the magnitude of difference. Sometimes that's not the case. Sometimes there are people like, oh yeah, I want to do everything that I can, so please prescribe please prescribe it to me. Or, they're surprised, but the TV commercial made it sound so promising. Why are they allowed to say that on the television? And I remind them that we also hear unrealistic messages about the beer that we're going to drink or the cars that we're going to drive, and that this is a common thing. So if you are supporting patients to make decisions that deviate from what the guidelines suggests is the best thing to do, this is what you do. You record your intellectual footprints. And this is a summary of advice from the CMPA, as well as some of the published literature. So you want to make sure that the rationale for why you're having the conversation is recorded, so that anybody reading the chart could know. So if you're away on vacation and you have a locum and someone comes in for a refill and your locum is like, well, why aren't they taking the triple inhaler? They have not gone through this process and not have shared that. It's immediately obvious what's going on. I often will talk to a colleague just to talk things through, like, does this sound completely bonkers if, this is the kind of stuff that I'm talking about with this patient? And that is, that's very reassuring to our medical legal overseers that we have done that process of checking in with a colleague. You want to have a clear plan for follow-up and monitoring. And then I've actually given you, this is a template that I have in my EMR, and I'm not going to read this here, but I just wanted you to know that there's a Word version of this text in the shared folder. And so I actually include what my estimate of the generalizability of the research that I'm considering is for this patient in front of me. I share what the estimate of benefit is that I have given. And in this, I'm comparing natural frequencies with all the limitations around the averages of per patient per year. I say what the choices were that I presented to the patient. I put what the patient's response was. And this is a shared decision about the COPD treatment. And I have just two choices here. There's many versions of this. In my EMR, I can cut and paste and add text very easily. And someone has said that they couldn't access the Word version when they tried earlier. We'll double check that posting for you to make sure that it's available. So our take-home messages about guidelines are that guidelines are a guide, and that the magical sauce of your relational continuity may provide you key reasons to support shared decisions that deviate from a guideline. You want to make sure that if that's happening, that you document your rationale and leave an intellectual footprint so that other care providers will be able to understand what you did and what the patient has said that they want. So in conclusion, Raj asked me, how long does it take you to do these visits with patients, and do you do your clinic note from start to finish? So the first part of that is, so I will have this kind of conversation with patients when I'm doing their annual complex care review. And so that's usually a 30-minute appointment. And then I have 15 minutes extra booked in for documentation. In British Columbia, we have an annual complex care fee that we can bill that is very generous and covers that time amply. And I will acknowledge that these things can take time. It might take a couple of visits, and that our fee-for-service delivery model of primary care that is used widely across Canada is very problematic for this patient-centered type of care. I always do my clinic notes from start to finish right after a patient encounter, or they don't get done. That has become a bigger problem for me as I get older and more busy. But I know that people can't do that. So I'm really interested at this point. We've posted the evaluation and the post-test in the chat again. We'd love for everybody to do that. You do need to do the evaluation if you want CPD credits. For our last remaining minutes, I would love to hear any final comments. Pam asks, how many communicate this plan on the discharge prescription, at minimum the indication? Yeah, that's a great question. So I've been writing indication on prescriptions for 3 years, and I have no indication that the indication has ever been included on a dispensed prescription. It never comes back to me. It's never on the refill request. So I think we've got some work to do there in that reason. Any other final comments that we have in our remaining 1.5 minutes? So grateful to everybody for joining in this experiment with us and for engaging using this virtual platform. And very grateful. Oh, actually, so there's another comment here that someone was actually taught in residency to never prescribe anything without an indication, at least in your note or in your mind. Absolutely. Yes, absolutely. Makes a lot of sense, but sometimes can still fall by the wayside, even though it makes so much sense.
Rita, just a comment about that. Sorry to interrupt. And in BC, pharmacists aren't required to type the indication on the patient's medication label. But if you put a little footnote that says, please add it to the label, that may make it happen. Just a suggestion that might work. Right now, they're not required by the bylaws to do that.
Yeah, there's also a private comment here that the type of inhaler device can affect a patient's ability to use it. And Kate, if I'm not mistaken, Pad's done a bit of work on that and looking at the different modalities of inhalation.
Yeah, and the RX Files 2 has a super handy chart, and the other academic detailing group from Saskatchewan about how to choose between devices. There are some limitations in our choices because pharmacare might, in a particular class, only cover some, but that's listed out in our PAD handout that Rita showed in the beginning. It's in your resources.
Yeah, so a final huge thank you for your participation and attention today. And we look forward to welcoming you to future TI events and engaging with you on social media, if that is part of your practice.
Thanks, everyone.
Take care, everyone. Check out the TI website if you have any issues accessing the resources. You can use the contact form there. And any other questions, we'll be happy to respond.